Hi, my name is Sarah Wang. My Polygence mentor's name was Emily Avery, and my topic is factors influencing the rate of clinical deterioration in Parkinson's disease. I chose this topic in lieu of my grandfather's recent diagnosis, and I'm currently zooming in from New Jersey. As for a quick overview, Parkinson's disease is a neurodegenerative disorder of the central nervous system that results in uncontrollable movements, and I aim to review research that has elucidated various factors influencing Parkinson's prevalence and disease course, as well as explore PD's unique and individualized nature and why the disease is so puzzling to scientists today. So some of the factors I will be discussing are genetic factors, environmental factors, impact of COVID-19, socioeconomic factors, and treatment options. So discovering genetic influences and factors of any disease, especially PD, is essential for those trying to understand its etiology. Genes like alpha-synuclein and COMT have been found to provide insights into the role dopaminergic systems have in developing cognitive impairment in Parkinson's disease. Other genes like ApoE and MAPT are associated with dementia and found in similar neurodegenerative diseases. In fact, a 2012 study based in Philadelphia sought to determine the association these genes had with cognitive decline in PD using records of annual change in the Dementia Rating Scale 2, or DRS-2 scores. The conclusion was that carriers of the ApoE4 allele show the most statistically strong changes, and the effects of the ApoE genotype on cognitive decline was also associated with decline in all DRS-2 subscales, which includes initiation, construction, conceptualization, and memory. A weakness of the study that it touched upon was that other studies have failed to find this association, referencing a past study from Cambridge that failed to find data to support ApoE4 effects in any association between cognitive decline and the E2 allele, in contrast to other studies that have found it to be associated with increased incidence of PD. To me, this shows that these diverse results only further undermine any evidence that certain genes are directly associated with cognitive decline. And this will become sort of a trend since we know very little there's very little known in Parkinson's disease that is actually concrete. In fact, commonly detected genetic variants also seem to differ based on location, as research has found that the PRKN gene is the most frequently detected causative gene in Japan. It is the causative gene of autosomal recessive juvenile PD and has been identified in over 2,000 cases. So the genetic influence of PD remains to be conclusively described in an ongoing area of research, and it remains challenging to conclusively distinguish genetic factors from other influences on PD disease courses. So as for environmental factors, this includes substances, job, housing, locations, and behaviors/habits. And for one, pesticides. Pesticides have been used globally in the agricultural industry and by public health authorities to control pests and disease vectors. In particular, the chemical compound, see if I get this right, 1-methyl-4-phenyl 1,2,3,6-tetrahydropyridine, MPTP, has been a point of interest due to its ability to target the substantia nigra. It is now concluded to be the only environmental agent identified so far that is capable of inducing Parkinsonism. This is a breakthrough in PD research, as finding anything definitive or conclusive relating to PD is, again, a huge rarity. Research later discovered that MPTP itself was not toxic, but metabolized by astrocytes in the brain to MPP+, which is also found to have a similar composition to paraquat, a commonly used herbicide differing by only one methyl group. These discoveries incited the idea that pesticide exposure may be related to PD pathogenesis and thus began continuous studies to investigate this possible relationship. Another environmental factor could be like heavy metal particles in the air. Some claims of association of elevated risk of Parkinson's disease and heavy metals have differed among studies and aimed at analyzing this correlation. Some says there is an association, others says there is not. Iron in particular has been identified as a potential association with PD. It kind of explains the amount of concentration of iron that PD patients have in their brains. Because typically a healthy brain has higher concentrations of iron in the substantia nigra and lower concentrations in the midbrain, cerebellum, so on and so forth. So regions of the brain involved with motor function should have higher concentrations, while the regions that don't should have lower concentrations. However, increased concentration of iron in the substantia nigra is also neurotoxic, and patients have had especially high accumulation of iron in the brain. So as for the impact of COVID-19, the pandemic is a fairly new factor that has been playing a role in association with Parkinson's disease. During the pandemic, everyone, including PD patients, were recommended to adhere to social distancing regulations, quarantine, and all public health guidelines. However, these regulations were also in direct contrast to pre-pandemic PD management, which included increased socialization and physical exercise. Routine exercise helps PD maintain strength, flexibility, balance, and cognitive acuity. However, gyms and community centers were closed because of these public health guidelines. Not to mention, the pandemic also had an effect on PD patients' mental health, since a study interviewing 38 PD patients using the DASS-10 scoring scale, the average depression score was a high number of 7, the average anxiety score was a high number of 4, and the average stress score was also a 7. However, in contrast, non-PD patients had an average depression score of 3, an anxiety score of 2, and an average stress score of 4. So stress can actually worsen PD symptoms, and so the combination of COVID-19 related stress and the limited resources to manage such stress undoubtedly could have led to increased severity of PD symptoms during the pandemic. So research has mostly provided conflicting results and is largely inconclusive on these claims. However, these are just logical conclusions that I made up on my own. As for socioeconomic factors, this includes income, employment, education, etc., anything to determine the choices readily available in a person's life, which plays a huge role in disease and healthcare in particular. Since lower socioeconomic status is generally associated with higher rates of disease, since it is unlikely for that those of lower SES are able to access proper healthcare, which leads, obviously, to a downward trajectory of increased morbidity and a further increase in poverty and inaccessibility to care. A 2009 study from Manitoba, Canada, actually found that the prevalence rates of PD were were higher in lower income quintiles for both rural and urban areas than in higher income quintiles, and that incidence rates were higher in the lowest urban income quintile than in the highest urban income quintile. So I made the conclusions that these resultant trends could have been attributed to a variety of factors. Perhaps these higher rates of PD in lower income quintiles can be attributed to previously discussed environmental exposures to heavy metals and contaminants, since it's more likely for those from lower income areas to take on manufacturing jobs, construction labor, etc., anything that may have such exposures. Another loose assumption that can be made is that lower income rural areas have greater exposure to environmental contaminants, such as previously discussed pesticides, and could theoretically have higher rates of PD. I also noted that these lower income areas have less access to proper healthcare, so it's possible that they may have never received a proper PD diagnosis and therefore were not included in the data involved in these research. So as for commonly accepted treatments now, what is most commonly used. Currently, many of PD treatment options are targeted to protect dopaminergic neurons or to rescue neurons at risk. Levodopa, an amino acid, is the most commonly prescribed treatment for PD, and it's used to replace dopamine in the brain to reduce PD symptoms of slowness, stiffness, etc. However, as are most conclusions, research, really anything associated with Parkinson's disease, levodopa is not a concrete treatment option and it is not long-term, as PD patients treated with the drug have seen developments of motor complications after 4 to 6 years. In fact, a 2004 study even evaluated the possibility of levodopa accelerating neurodegeneration instead. Another popular treatment option is the usage of dopamine agonists, a group of medications that activate the dopaminergic receptors by mimicking the role of chemical messengers in the brain. Except these are also have short-term effects like levodopa. And also alongside these medications, exercise speech therapy and physical therapy interventions are also common non-pharmacologic treatments targeted at improving PD symptoms. So in conclusion, PD continues to present unique challenges to scientists and researchers today because of how little concrete information we know about it. And so because of the limited knowledge we have relating to PD as a whole, the best thing that we can do at the moment is to keep continuing research efforts, advocating for comprehensive care and supporting those in the PD community to both enhance our understanding and improve the lives of those affected by this condition. Thank you for listening.